Good evening, everyone, and welcome to the Maddie Riewoldt Vision 2026 series of patient and family educational sessions on bone marrow failure syndromes. My name is Jaya Soma, and I'm the National Manager for Research and Patient Programs at Maddie's Vision. Before we begin, I would like to acknowledge the traditional owners of the lands on which we each meet today. I'm joining from the lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to their elders, past and present. I also extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. As many of you know, Maddie's Vision is the only organisation in Australia driving bone marrow failure syndrome research, advocacy, education, and support for patients and families. We have now funded 10.6 million across 40 cutting-edge research projects and have multidisciplinary collaborations in place with 28 leading research institutes across Australia and internationally. We are the source of support for bone marrow failure syndrome patient and family members through our tele-support service and peer support program led by our lovely nurses Mei-Ling Ye and Rachel Penny. We have now supported over 190 patients and families nationally and invite any of you here tonight who have not yet connected with these services to please reach out. We are here for you when you need us. Please note that this evening's session is intended to provide general information and education only. We are unable to provide advice about individual patients or specific medical circumstances. If you have questions about your own or a family member's care, we encourage you to speak with your treating healthcare team. Our program this evening will focus on Shwachman-Diamond syndrome, how care is currently managed, and how research is continuing to advance our understanding of this rare condition. Following the presentation, we will hold a question and answer session, and we thank those of you who submitted questions in advance. Our speaker has endeavoured to address these throughout the presentation. If you have additional questions, we invite you to ask them during the Q&A. I'm now absolutely delighted to introduce Dr. Lorna McLemon. Lorna is a paediatric oncologist at the Royal Children's Hospital and a PhD candidate at the University of Melbourne based at St Vincent's Institute of Medical Research. She has a special interest in bone marrow transplant and advanced stem cell therapies, including precision gene editing. Please join me in welcoming Dr. Lorna McLemon.
Thank you, Jaya. I'm just going to share my screen just a moment. Well, thanks so much for the introduction, Jaya, and I'm really happy to come and speak here tonight. I've done a couple of these sessions now, and I've really enjoyed them, and it's just a great opportunity to connect with everybody outside of the clinical space. So thanks again. My name's Lorna. As Jaya mentioned, I'm a paediatric oncologist specialising in BMT and leukemia at the Royal Children's Hospital. And bone marrow failure is very dear to my heart. My PhD studies are investigating novel gene editing techniques for another inherited bone marrow failure disorder named Fanconi anemia. So looking forward to talking to you tonight. I've tried to put together a talk sort of going from the basics forward. So we'll talk a little bit about the biology of SDS, how young people present to us in the clinical space, what our diagnosis criteria looks like, and then some of the key factors for SDS that we're considering as clinicians, including clonal hematopoiesis and how we surveil for that. And I'll talk a little bit about bone marrow transplant, which is obviously the area that I'm involved in. And I put a couple of slides in there also about what we're hoping to bring in the future. So I've just sort of put this slide in as a bit of an overview of the bone marrow failure disorders that we manage in the clinical space, and by and large, the most predominant bone marrow failure that we care for are patients who have severe aplastic anemia. However, there's a number and a growing number of inherited bone marrow failure disorders affecting our patients, which we're learning more and more about. and Shwachman-Diamond syndrome being one of these, which was first described in 1964 by Harry Shwachman, this gentleman here, and Diamond, who were clinicians in the States, and also an ophthalmologist named Bodian. So sometimes you'll see in the literature this entity named Shwachman-Bodian-Diamond syndrome. This is just a sort of brief overview so we can sort of set the scene, I suppose. So Shwachman-Diamond syndrome, I'm managing patients in the context of bone marrow failure. However, this is a multi-system disorder, and it's caused by a genetic defect in genes that control the ribosomes, which I'm sure many of you are well aware of, but we'll go through just as a reminder of the basic biology to help us set the scene for the rest of the talk. And the ribosome's the part of our cell that helps build proteins. And as I've mentioned on the slide, defects in SDS are caused usually by mutations within the SBDS gene and associated genes, which mean that we have a lack of SBDS proteins in the body, and that means that our ribosomes don't function properly. So the cells in the body that can't produce critical proteins and they can't survive. And the prevalence is around you can see there, roughly 1 in 80,000 live births. And with our annual birth rate in Australia, that equates to around 3 new diagnoses per year. And we'll look a little bit, as I say, about where diagnosis and treatment's heading. So I hope this is not too basic for everyone, but I guess just kind of going back and setting the scene when we're thinking about DNA and genetic variants, we've got 22 pairs of chromosomes in each cell, plus either XX or XY. And this is the structure of the chromosomes. And when we look at that in a little bit more detail, there's DNA here, which is kind of wound up into the chromosomes. And it's in every single cell of the body. And it tells the cells in our body what their jobs are and allows them to interact and to function properly. So how do we how does DNA actually do its job? Well, this slide is showing the central dogma of molecular biology. And what that is that DNA within the nucleus of our cells is converted to pre-mRNA. And there are different parts of DNA, and when you unwind that raveled DNA, there are coding regions named exons and non-coding regions named introns. And in a process called splicing, the non-coding DNA that doesn't encode for proteins is removed. And this makes mature messenger RNA that's ready to leave the nucleus and go and make its protein, which is the building block of a cell, and the ribosome is really critical for that. And this diagram here is just showing you what it looks like when splicing occurs, when those introns in the DNA that aren't required are removed and all the exons that are required for coding proteins are joined together. And this happens with a part of the cell named the ribosome. So the ribosome is reading the messenger RNA, and with the letters that it reads in the messenger RNA, it's growing an amino acid chain and building a protein, which has a specific job within a cell. So it's the instruction manual for the body, essentially, a really long code. It's written using 4 different chemical letters. And a gene of the DNA is like one chapter of a big manual, and it contains the instructions that tell us how to build those proteins. And if there's a variant within that code, sometimes it can be a variant that doesn't actually change the meaning. However, if we have a variant like I've shown on the screen here, it's not saying protein anymore. It's a word that is sort of meaningless, and it can end up causing real issues and changes in the proteins that are developed. Either too little is made or protein that doesn't do a very good job is made. So for Shwachman-Diamond syndrome and for many inherited bone marrow failure disorders, there's actually not just one gene or one mutation or variant in a gene that causes this problem. And I've shown you on the slide here there's a large proportion of Shwachman-Diamond patients who have variants and mutations, which we use interchangeably in the SBDS gene. And usually that's on chromosome 7 in the region of 7q11. But there are some other genes that are also associated with causing the same problems with ribosomes, including EFL1, DNA JC21, and SRP54. And these are less frequently found in the population, as you can see. And sometimes there's patients who have clinical features very much in keeping with Shwachman-Diamond syndrome, and we can't actually find the pathogenic or the variant in the DNA. This is a schema which just shows what happens in the most common mutation that we find in SBDS, which is at the boundary, as I mentioned. And the reason that I mentioned splicing is that this mutation occurs just after exon 2, and that's remembering that it's the coding region of the DNA before we come to code the intron. And when we have a problem and a mutation there, what it does is that it causes like a premature stop signal to the ribosome and means that the ribosome stops producing the SBDS protein, and you get what I'm showing you here. So instead of getting the full green working protein that's produced by the ribosome, you get this incomplete non-working protein, and it's not doing its job properly, and it means that we get specific problems within the cells. So Shwachman-Diamond or SDS is a ribosomopathy. So it's a problem with the ribosomes. These SBDS proteins are critical for joining the subunits together and making the protein. And it's sort of, they're like, there's two different subunits to a ribosome, and they come and dock together on the mRNA, and that's the process by which they're able to then produce the amino acid chain and make the protein. So how do we inherit these genes? Well, for the most part, and there is an exception that we'll talk about, but is significantly more rare, you need a problem on both of the copies of the gene. So, we inherit a copy of our gene, one from our mum and one from our dad. And if somebody has two working copies of this gene, then you don't have Shwachman-Diamond. If you have one working copy of the gene, but you may have inherited the mutation on one of the copies, either from mum or dad, or in some instances it's just come up by itself, what we call de novo, then you will be a carrier for SDS, but you won't have the symptoms. And if, of course, there are two copies inherited, then you do end up with Shwachman-Diamond syndrome. Most of the genes that cause Shwachman-Diamond are inherited in an autosomal recessive inheritance, and that's what we've just sort of discussed. So two parents will be a carrier. There'll be a 50% chance that one of the offspring or the children will also be a carrier. A 25% chance that they will inherit the two healthy copies of the gene and they won't have Shwachman-Diamond, and a 1 in a quarter, so a 25% chance that they will. The exception to that rule is, as you could see, the much rarer genetic mutation that's associated with SDS is the SRP54, and that's one that's more recently been documented in the literature. And this is inherited in an autosomal dominant pattern. And what that means is that you only need one parent to have an unhealthy copy of the gene for half of the children to have a risk to be affected. So you don't need both copies, one from each parent. This is enough to have the symptoms of SDS. And what we also see sometimes in patients, and it's important to be aware of that, is that one parent may have a healthy and an unhealthy copy of the gene. The child has inherited that unhealthy copy, but then they've developed themselves within their own body a random new mutation. And sometimes it's not exactly the same mutation, an area of the gene on each copy that ends up causing Shwachman-Diamond syndrome. So what do we actually see in patients? How do we diagnose this, and how do we know it's occurring? And classically, there was a triad that was described right back in the 1960s of this multi-system disorder, that patients had problems with, we call the exocrine function of the pancreas. How that presented was young people who were struggling to put on weight, who had symptoms that they were not absorbing their food very well, and that results in something called steatorrhea, or stools that look sort of fatty and a bit strange. And vitamin deficiencies, because the cells of the pancreas are really important in producing enzymes which help us digest our food. The other part of the triad, and I've just put up here, in the largest cohort that's been described as Shwachman-Diamond syndrome, you can see that nearly all patients will have some issue with pancreatic function. The other part of the triad was issues with the bone marrow cells and the bone marrow. And classically, we'll talk about this in a little bit more detail, but you can see that, again, very many of the patients will have problems to some extent, some more mild, some more severe, of problems with the bone marrow producing blood cells. And then there were also a smaller but significant proportion of patients that had changes within their bones and the structure of the bones. And that could lead to a shorter stature than you might see in their other age-matched cohort, with delayed bone development, with changes within the growth plates of the bones, and sometimes even in more extreme cases in young babies, of changes in the shape within the rib cage. And there are other associated symptoms which we can also cover. So why does Shwachman-Diamond cause pancreatic insufficiency? And it's actually that the problem with the ribosomes impacts pancreatic acinar cells. And it's usually apparent within the first year of life. However, like I mentioned, it could be quite variable in severity from one person to another. Usually what we see, particularly on imaging of the pancreas, is that there's fatty cells that infiltrate the pancreas, and it may be a bit smaller in size than would be expected for the young person's age. And those acinar cells are the ones that produce the pancreatic enzymes, D, E, A, and K, that allow us to digest our food properly. And without them, we will swallow fat and eat fat, and then it's excreted without being digested, which is why the stools sort of look greasy. And that's the process called steatorrhea. And it also means, because you're not absorbing your nutrients, that poor weight gain, and there is problems with growth. And there are other gastrointestinal tract changes which have been seen in young people with SDS, which includes sort of a generalized inflammation in the gut that we call an enteropathy. And that might be why in some children with SDS, we still see faltering growth despite the supplementation of pancreatic enzymes. So this is not quite so common, the skeletal abnormalities that we see, but there are specific things that need to be reviewed. So in about 40 roughly % of patients, there will be changes in the metaphysis of the bone, and that's the area around the growth plate. And when there's problems with the area of the growth plate, it means that the bones don't always grow to their full potential, and that's why we might see short stature, and that's reported as roughly about half of the patients that have been diagnosed. And in a much smaller proportion of patients, you can see these sort of, it's thoracic cage abnormalities, but you can see the shape of the ribs is a little bit more, there's more curvature there, and there can be a sort of smaller thoracic rib cage in a proportion of cases. And if this is very severe in newborn babies that are born, it can cause some problems with the expansion of the lungs and breathing, though we don't see that very commonly. And another important area for surveillance is dental. And we do sometimes see tooth abnormalities, which occurs from just growth, which is atypical, or potentially also exacerbated by the fact that some of our patients have malnutrition because of the pancreatic insufficiency. So getting down to the other area of the triad, so the third part of the triad is bone marrow failure that we see in Shwachman-Diamond syndrome. And SBDS protein deficient blood stem cells, which are the cells that differentiate down these two pathways, the lymphoid and the myeloid pathway, to produce all the blood cells within the bone marrow of your body that then get pushed out into the bloodstream that are critical for life. And if we're deficient in the SBDS protein, then those stem cells actually can't produce the blood cells in the number that they're required, and we will see commonly initially a lower neutrophil count. And neutrophils are very important for protecting the body against infections, specifically bacterial infections. So when they are very low, that can be an issue. And then typically we would see a low platelet count. And if the bone marrow is severely affected, then the red blood cells, the erythrocytes here, will be affected too. A low platelet count causes changes within the body because platelets are required to prevent bleeding, and they are the cells that go to an area where we might have had a cut or a scrape, and they cause scabs. And so when they're low in number, we can have bleeding problems. And a very typical rash, which is called a petechial rash, on the body when we get a bump or a knock. And when the red blood cells are low in the body, these are the cells that are required to carry oxygen to different tissues and so people can feel quite short of breath. People can feel quite tired when those are low. And when all of the bone marrow has reduced in, depleted in number, and the lymphoid compartment, which are another part of the immune system that's very important for protecting against different types of infections, then we will sometimes see young people that have more atypical or longer lasting viral infections or even fungal infections, which require a different type of treatment. So we manage the infection risk in patients that have been diagnosed, and we use preventative antibiotics, antivirals, and antifungals where required. But looking at the sort of number of cells and how low the cell count is, and we call that a cytopenia, such as we have specific numbers we look for. So if the platelet count's less than 20 and the hemoglobin's less than 7, and the young person is requiring transfusions of platelets and red blood cells, this is one of the indications to us that this person may be heading towards a bone marrow transplant. And we'll talk about the other indications later on. So there are many other features actually that have been reported of SDS, and I don't have time tonight to go into all of them in detail, but just to say that liver dysfunction is commonly seen in these young people, and we do sometimes see that improving with age. We can see skin changes and rashes. Sometimes hormone production is affected, particularly the pituitary gland, which produces many hormones which are critical in the body. And we do sometimes see structural changes in the hearts and kidneys of young people who have been diagnosed with Shwachman-Diamond syndrome. So these have been associated. And the other thing which is important for us all to sort of be aware of and recognize and follow up is that the largest cohorts of Shwachman-Diamond syndrome patients are reported in the literature also have had some changes within their behavior and sometimes with their ability for learning and sometimes needing extra support in this setting. So another thing that's really important for us to be aware of. We usually diagnose young people around the age of 3.5 when the growth faltering has been apparent. But we do have seen patients much later than that if they have a less severe growth failure. So that's generally sort of the timeline. There are obviously some adults which have been diagnosed too. And how do we diagnose Shwachman-Diamond? Well, we may obviously suspect this with the duo that we see, a pancreatic dysfunction, which we can review on both clinical symptoms, but also there are some particular tests that we can do both in the blood and the stool. and imaging can also help us with that. And then when we're reviewing peripheral blood draws for low blood cell counts. And if we are suspicious from a peripheral blood cell count, then we do really need to confirm that with a bone marrow biopsy, as this is where we will get more detailed testing. And in a bone marrow biopsy, we look both at the how the cells actually appear under a microscope, which is called their morphology. We also look at the surface cell markers, and we do genetic testing, including microarray and FISH, and importantly, looking at next generation molecular sequencing, which helps us in surveillance, and we'll talk about why that is shortly. And there are other sort of supportive clinical features that we might see in a young person that might also raise our suspicions of SDS. For example, any of the bony changes that we've spoken about, any of the liver function changes that we've seen, or somebody that's having problem with their growth. This is a concept that I think is really key for both families and clinicians that are managing Shwachman-Diamond. And I wanted to just briefly talk about what clonal hematopoiesis is and how that plays into our surveillance and why surveillance is so important in this condition. And this is where one of the blood stem cells that we spoke about previously, those cells that are able to produce all of the important cells within the bone marrow, over time, it's possible for young people to pick up an additional genetic change within those blood stem cells. And in some instances, that change that the cell picks up allows it to actually have a growth advantage over the blood stem cells that are growing next to it. And sometimes this is beneficial and sometimes it's not. And so depending on the mutation that's picked up within these stem cells, it kind of helps us to surveil and delineate those patients that might have a higher risk of transforming towards myelodysplastic syndrome and leukemia, which is the biggest risk for Shwachman-Diamond patients, or those patients that might have picked up an additional mutation which actually helps the ribosomes work and helps the cells grow healthily. So these particular things that we're looking for, these mutations and that allow stem cells to grow that can be positive, are variants that are picked up in EFI6, the gene, and also we see particular structural changes in the chromosome, such as isochrome 7q or the deletion of 20q. And when these clones are found during surveillance for a young person, then that would be an indication to us to continue to review and actively surveil, but is not an indication to move forward with treatment unless, obviously, as I mentioned, there's tricky and troublesome low blood counts which are causing transfusion dependence. It is quite common in all inherited bone marrow failure syndromes and also in Shwachman-Diamond syndrome, however, to pick up the addition of a mutation called TP53. And when we have TP53 loss, this is actually like it's like taking the brakes off the cell and a signal that the cell can have multiple different additional mutations. And these are the things that predispose to the bone marrow spitting out stem cells that don't look correct, and we call those dysplastic, and that's usually a precursor to developing a type of leukemia called myeloid leukemia. And obviously leukemia requires significantly different treatment from patients that don't have these clones. So it's really important for us to review the clonal population and clonal evolution of patients with Shwachman-Diamond. And it's also very personalized to people and helps us determine what treatment's required. This was a fantastic paper by one of the world experts who has spoken previously at Maddie Riewoldt's Vision conferences, and her name is Akiko Shimomura. And her group really eloquently showed this process in this paper. And I just wanted to show you a couple of figures from here, which sort of re-explain what I was talking about with clonal evolution, because I think this is an important thing to cover. So this is one patient. So figures A and B are reviewing the different clones within the bone marrow for one particular patient. And you can see that there was 3 different clones. There was a TP53 clone that was present on both copies of the gene. There was a TP53 clone that was present on one copy of the gene. And there was this protective mutation in another group of stem cells called the EIF6, which was the one that we previously spoke about that helps the ribosomes work properly. And initially, it looks like these are all quite stable. This is something called the variant allele frequency on the side. And I guess the only thing to mention there is that when we get up towards the number of 1, that tells us that there's lots of these mutations and they're on both copies of the gene, and it certainly makes us more concerned. And you can see over time in this young person that the protective clonal population has unfortunately reduced. And this clonal population with the solid red line here, I don't know if you can see my cursor, hopefully, has increased. And this patient then developed myelodysplastic syndrome. And that's what we're really carefully trying to review. And I'll explain to you why, but essentially catching these young people and patients before this occurs, if possible, or certainly before leukemia occurs, is really critical for helping to cure this problem. And again, it's just another visual of how this happens. So we might have the either the problem stem cell that has picked up a TP53 mutation, but then unfortunately, because that gives the cell a proliferation advantage over all of its neighbors, it's actually able to keep growing, and more of these TP53 SDS stem cells can occur, and then the likelihood of picking up a leukemia called acute myeloid leukemia is much more common. And that's why this sort of early warning system in surveillance is so critical, and helps us plan a timely transplant. So bone marrow transplant is the current only curative therapy for patients who have transfusion dependent, so not transient, but permanent transfusion dependent blood counts, or those who have already developed MDS or acute myeloid leukemia. Or those people who we are suspicious when we watch a rising TP53 clone that we want to catch before that turns into myelodysplastic syndrome or leukemia. There is a great published recommended surveillance schedule for people with Shwachman-Diamond. At the Royal Children's Hospital, it may be a little different in the adult setting, but I'll just explain to you what we do. So we usually, in the surveillance setting, perform bone marrow biopsies at least annually, unless there's any indication to us within that year that we need to be having a little look more frequently. But usually it's annually for us. And that allows us to look at both the morphology of the cells. So do they all look like normal cells? There's no evidence of myelodysplastic syndrome, as well as looking for those genetic changes that I've mentioned. So the clonal populations that may be protective. Though I must say more commonly we see the TP53 mutation that can indicate to us that a young person may develop myelodysplastic syndrome or AML. And it's worth saying, I think, that those TP53 clones in themselves are not an indication for bone marrow transplant. And as we'll talk about, it's not a treatment without its own toxicity, but you do see variation over time. So there may be some people who develop a TP53 clone, but that peters out and a protective clone occurs. So just having that diagnosis of TP53, unless it is a markedly increasing clone, like we saw on the graph there, or a person has other indications that they may be developing dysplasia within the bone marrow, or they've got problematic transfusion dependence, needing lots of red blood cell transfusions and platelet transfusions, that in itself isn't an indication. And there are other surveillance schedules that we sort of try and follow as well, looking at the liver function tests, looking at, from a nutritional and pancreatic perspective, our fat-soluble vitamins. We do bony imaging at growth spurts, but less frequently. And we'll also check endocrine function, particularly for the pituitary gland function that I mentioned before. And all young people should be linked in with their dentist, whether it's at the hospital or locally as well. So maybe I can go now into talking about treatment. And so obviously my focus is going to be on treatment of the failure of the bone marrow, whether that be just low blood counts or whether that be, like I said, the predisposition to malignancy, so myelodysplastic syndrome or acute myeloid leukemia. And some patients, if they've gone, through that process and have developed leukemia, then occasionally may need a chemotherapy to bridge them to a bone marrow transplant. But bone marrow transplant is curative for the bone marrow compartment of Shwachman-Diamond syndrome, remembering that a transplant will only provide an immune and stem cell overhaul for that compartment, not for the rest of the cells in the body that are still containing the defective SBDS protein. So a transplant would not cure the pancreatic insufficiency. It wouldn't change skeletal abnormalities, for example. And I think this slide in itself, is just a key indicator to us how teams within the hospital cannot work in isolation clearly in doing our best care for our patients, because there's so many different organ systems involved. We really need to work closely with our gastroenterology team, our endocrinologists, our specialist nurses, and our allied health team, and also thinking about neuropsychological services and support, I think, is really key. And I'd love to hear some of your opinions about that at the end of this talk, but we'll finish talking about transplant and future therapies first. So what is a bone marrow transplant? There's two different types of bone marrow transplant. There's one that we call autologous, where somebody receives their own cells back. This is not what we are discussing for Shwachman-Diamond currently. We're talking about an allogeneic stem cell transplant where you receive stem cells from a donor. And that replaces the faulty blood stem cells with healthy donor cells, and those healthy donor cells are then able to differentiate into all the blood cells that are required, and you cure the bone marrow failure for those patients. And I think I've spoken, about the indications we use for bone marrow transplant. So having a diagnosis of Shwachman-Diamond alone is not an indication for transplant, nor is having a TP53 clone alone, but having a rising clone or the early development of myelodysplastic syndrome or tricky persistent transfusion dependence is. And this is it's quite a prolonged process planning for a bone marrow transplant, and also it can't occur unless we have a donor. So that sort of search is usually happening during surveillance, or certainly at least looking at the typing of a patient's stem cells and trying to do sort of the family tissue typing as well to see, should we need a transplant, who do we have, because that search can sometimes take some time, particularly if we need to look for unrelated donors. And unfortunately, some people don't have a well-matched donor, and that's why some of the novel therapies that may be coming in the future will be really key. So I'm just showing you this slide again. I know we've already reviewed it, but just to go back, what does it actually mean to have a failing bone marrow, and why is it so important? Well, it's so important because this is the thing that you can't live without, that you need these cells to be working in the body. Without them, and without platelet transfusions, you would bleed, you become very anemic, and you'd be at risk of really severe and unusual infections that can be really tricky. But it doesn't always happen quickly and instantly. Sometimes it's a process over time. And I think, like I had previously mentioned, we quite commonly will see sort of a reduction in the neutrophil count, which precedes any changes in the platelet count, which also precedes any changes in the red blood cells. And we want to replace these defective blood stem cells, and that's what a bone marrow transplant does. The donor cells replace those SDS stem cells that aren't working well. There's a lot of planning involved in a bone marrow transplant, a lot of investigations and discussion that occur prior to a bone marrow transplant. And like I said, finding an appropriate donor is essential. Whilst I haven't spoken in detail about bone marrow transplant donors, there is a hierarchy of donors that we preference, and having a matched related donor, in our case often that will be a sibling donor, is our preference. And of course, that's why it's important that families are tested not only for how closely the stem cells match in a process called HLA tissue typing, but also that young person also does not have Shwachman-Diamond syndrome. This is a schema that, I'm not sure who on the call has, or families have been through a bone marrow transplant or not, but I think if you haven't and you haven't had a conversation about it, it can be quite a difficult thing to imagine before you go into this process. And I think that's also what we see for our patients, when we're transplanting young people that have had a long process of chemotherapy and come to a bone marrow transplant, there's maybe less of a transition. But in young people who have not really been long-term inpatients of the hospital, this can be quite a shock. So it's an inpatient procedure, and usually young people are in the hospital for at least 6 weeks at a minimum, in a units called bone marrow transplant units, which have some specific sort of restrictions on who can visit the young person, on the nutritional intake, and yeah, it's an intensive process. And so if we've required a transplant, we've been able to find a bone marrow donor, we use it to, as I said, to replace these defective or underfunctioning cells. And that's not always that easy to find. It's not a guarantee that we will have a donor. If you have a sibling, there's about a 1 in a quarter chance that sibling will be an HLA match. So we'll have those stem cells matched, which is very important for the transplant to work properly. Otherwise, the cells just get spat out and rejected from the body. But obviously that person needs to not be a patient who has Shwachman-Diamond themselves. And otherwise, we have international bone marrow transplant registries of donors. And in some instances, if a bone marrow transplant is critical and time dependent, and we can't find a donor that way, then we use a parent, which is called a haploidentical donor. And the process itself looks a little bit like this. So we first you're in the hospital, we need to use something called conditioning chemotherapy, and that's highly intensive chemotherapy, which helps to break down the stem cells within the bone marrow and essentially sort of make some space for the new donor cells to hone to their bone marrow and then to start growing. And the choice of chemotherapy, the conditioning chemotherapy, is there are guidelines produced, but it's often quite personalized and dependent on where someone is in their bone marrow failure journey. So whether they just have low blood counts without any development of myelodysplastic syndrome or leukemia. And then we usually use chemotherapy, which is called reduced intensity. or if there's already development of acute myeloid leukemia or myelodysplastic syndrome, we don't use that typically, and more commonly we'll use something called myeloablative conditioning. So that makes a bit of space. Usually it's no longer than this duration, so about a week. Um, and uh, and at the what we call the day zero. So we have a funny way of denoting bone marrow transplant. Every day towards the stem cell infusion is minus days up until day zero, and every day afterwards is a plus day. So +1, +2, for example. Um, Usually the chemotherapy is multi-drug, and we have drugs that target the myeloid compartment and drugs that target your immune system, the lymphoid compartments. And the stem cell infusion itself, what it looks like is very similar to receiving a blood transfusion or a platelet transfusion. There's just a bit more intensive monitoring during that time, and it hangs like a bag of blood essentially and goes into a central vein. And usually our patients will have a central line that they will have had placed prior to the transplant to allow that to happen. It's very incredible thing to have this transplant as a cellular therapy, but actually day zero is often not quite as exciting. And then the main thing about a transplant is actually not these sort of running up days, but more the days after that. So significantly, the sort of the acute period where the patient's in the hospital, and they obviously, because we've used the conditioning chemotherapy, they have a bone marrow that's essentially like a failing bone marrow. So they have no neutrophil counts, high risk of infection. And even when those neutrophils from the donor cells engraft, so that they've gone to the bone marrow and they've started to grow for a subsequent of 3 days subsequently, there's still an immune system that's like a brand new baby and very prone to infection, at risk of sort of very specific viruses and funguses and bacteria that really require extremely careful monitoring. And then the more complex immune cells that took your body as an infant some months to years to develop, slowly will then start to develop. And we usually say by about day 100, that's starting to occur, if not has occurred. But sometimes it can take significantly longer than that. There are some specific complications that can occur with a bone marrow transplant, and I think that was one of the questions that we received. So I can't go into sort of detail on everything, but as I mentioned, infection is one of the major things that we're looking for in the inpatient setting, but also then still monitoring for certain young people when they've left the hospital and are still being reviewed very closely in the outpatient setting. And this can be very difficult actually for young people. I'm just thinking about location for people that don't live near a big tertiary hospital in Melbourne, then it often means a relocation for families closer to the hospital, not only for that inpatient time, but for the immediate sort of a post-transplant period. And that can be sort of really difficult for families. So I mentioned infection. There's another sort of a generalized complication of overhauling your immune system is that we get these sort of what we call early endothelial complications, and you can cohort a lot of different syndromes under that. But basically what it is it's dysregulation of the immune system in very small vessels in different parts of the body. So when the stem cells engraft in the bone marrow, that can cause a bit of an immune surge and people can be a little unwell there. And on occasion, we need to use treatment to help that. And typically that's steroid treatment. There's another complication that can occur usually in the first sort of 3 weeks post receiving the conditioning chemotherapy, and that's called veno-occlusive disease of the liver. And it's essentially inflammation in the very small vessels in the liver that can sort of block the liver up, and it can sort of trap some of the platelet cells in there and cause some issues related to that. And again, we have specific treatments for VOD should it occur. And we know that all of these things are complications, so we're monitoring for them very carefully in the in and outpatient setting. There is a condition that affects the small vessels of the kidneys, commonly, though it can be in other organs, and of course, graft versus host disease, which can happen either in the acute period up until day 100. Then we have a bit of a crossover of acute versus chronic, and it can happen much later post-transplant. And this looks a little bit different. And commonly, GVHD might affect the skin, causing rashes. It can affect the liver, causing changes to the liver function tests, and it can also affect the gut, causing problems with digestion, causing diarrhea, and needs some quite sort of specialized treatment and management. In those graft failure, it is so when the graft doesn't engraft or rejects is a problem, but we don't see that very commonly, mainly because of the newer, more specific versions of HLA typing, and obviously for patients that have developed leukemia, AML, that then relapse of the leukemia remains a troublesome complication. And I think I only put this slide up to, I guess, reiterate the importance of surveillance for young people with Shwachman-Diamond, because the outcomes depend on the timing of the transplant. So we do see that people who have not developed myelodysplastic syndrome or acute myeloid leukemia in the literature generally do better. And I just wanted to, I've just realized I'm really running a bit short on time, so I'll try and go a bit quicker. But I wanted to talk to you about some of the really exciting research and future therapies that are being investigated. And I guess it's important to understand that there isn't a current approved therapy that targets the root cause of Shwachman-Diamond, and transplant remains the only cure for bone marrow failure. But SDS is a one gene, a monogenic, generally inherited rare disorder, and there is a lot of drive both nationally within Australia and internationally to produce therapies that can target these gene changes that are not just a bone marrow transplant, which, as you can see, has with it its own issues. And there's a huge sort of growing infrastructure of patient registries, of biobanks. That's why I'd encourage you to sign up to these things when requested. And all of these approaches that are under investigation, I should say, are preclinical, so are not currently available for patients in Australia, but we hope that we will have them in the not too distant future. One of which I'll talk to you about in a little bit more detail is gene editing. And a couple which I won't speak to you about in detail today are preclinical models of something called antisense oligonucleotides and small molecules which can help release the EIF6 break, remembering that was the protective change within the ribosomes, and also some read-through drugs. And I wanted to talk to you about one really, I thought, really exciting paper that was published recently about a drug called ataluren. And this is a drug that was originally used for a different purpose, used in patients with Duchenne muscular dystrophy. And because of this, there's a lot of evidence with using this in patients, and sometimes that can then speed up the time frame from the preclinical research. So by that, I mean the laboratory research to getting this treatment to patients. And you remember I mentioned way back at the beginning of this talk, the most common SBDS mutation affects the protein synthesis by producing that sort of premature stop signal to the ribosomes and stops the ribosome producing the working SBDS protein. And this is a really interesting drug, and the category of drugs called a read-through drug. And what that does is essentially allows the ribosome to ignore that stop signal and keep reading through the messenger RNA and continue to produce a working SBDS. So in theory sounds great, and preclinically had some really interesting data published, and is in this is in the sort of stages of future clinical trial development. But in this paper, they treated a very small number of patients, but that's the nature of rare diseases. They treated 3 patients and they had some quite promising results, both showing an increase in these are their de-identified patients, so that's why they've got numbers, both in the numbers of cell counts, the neutrophils and the platelets. This is pre and post Ataluren. And also, which I think was really interesting, in the production of pancreatic enzymes. So unlike bone marrow transplant, which only will improve the bone marrow compartment, Ataluren has the potential for also improving the production of SBDS in other tissues. So it's very exciting. It's in further stages of clinical trials, and certainly something to watch. And then I will very quickly do a bit of an overview about gene therapy because I guess that's my area of interest, and also there's a big drive towards trying to bring gene therapy for different types of rare inherited disorders, and SDS is one of those. So a gene therapy it's a genetic system that has 2 major components. And there's 2 sort of molecular parts of a gene therapy. There's one part which helps find a particular site in the genome, in the DNA. And there's another part which is like a pair of scissors and can make a cut. And there's many different types of gene therapy. Some will then put in a particular gene or part of a gene that can help us produce proteins. Some are a little bit more novel and can actually overwrite that particular area, and even change different letter changes, so base changes. And that's all being investigated in SDS, quite excitingly by the group that produced gene editing technology for sickle cell, which is approved in the States. And this, I think, is so at the Royal Children's Hospital, we've had one gene therapy clinical trial open, and this is roughly what the, not for sickle cell, but for a type of inborn error of immunity named SCID. And this is essentially what it would look like in comparison to transplant. So it's not requiring a donor, because the cells come from the patients themselves. Usually those cells are taken from the body in a process called apheresis, so they're collected. Then external to the body, the gene therapy or editing technology occurs, and then the cells have the correction, so no longer have the gene variant that causes the problem of SDS. Typically, in most gene therapies, there is also conditioning chemotherapy required to make a space in the bone marrow, though there is discussion about Shwachman-Diamond syndrome potentially being a condition where that could be discussed, whether or not conditioning chemotherapy is required. But for most gene therapies, it is. And then again, the cells with the corrected healthy cells would be infused to the patient on day 0. And because you're not giving an overhaul of the immune system of a donor, you don't have any risk of GVHD. We don't need to give immunosuppression to the patient. And potentially this could lead to less toxicities, but there's a lot of things that are, I guess, barriers in place to this happening. Not only the fact that a specific type of gene therapy needs to be produced, which has not occurred yet for Shwachman-Diamond syndrome. And then there's some regulatory and funding hurdles. These are extremely expensive therapies, so getting them through the government drug agencies and approved, even once there has been a clinical trial to prove that one has been effective, will be tricky. And there's a big group of people internationally and also within Australia trying to forward this process. But I think exciting options potentially in the future are not currently available here. So I'm sorry I went a bit over time, but I'm very happy to answer any questions if anybody had any. And yeah, thanks very much for listening.
We're so grateful for everyone for attending tonight. We hope that it's been helpful for you and your families. And special thank you to Lorna for generously sharing your time, knowledge, and expertise with us this evening. We will be sending a short survey early next week. We'd really love your feedback so we can continue to improve and shape future sessions. Tonight was our 3rd session for the year, and we will be holding our final session in November on the 24th, which will be a collaboration with Team Telomere. So please keep ears open for that, which details will be shared soon. So that does conclude the formalities for the evening. We thank you so much once again for joining us, and we hope to see you at a future session. Good night.